Hello, welcoming you for the NEET May 2022 Microbiology recall questions. So these are the questions we got it from you. Few choices or something little changes may be there without affecting the core thing, because many times you know the correct answer means you know only the correct choice. Other choices difficult to get, but we manage as per the information given by you. So first question, patient was started on hot highly active antiretroviral therapy. What is used to monitor the efficacy of the treatment? See, usually the efficacy of the treatment monitored by two ways previously. One is clinical. Any clinical improvement, there is reduction of opportunistic infections like. Second is CD4 count. CD4 count, but CD4 count is not a reliable marker. It is cheap, affordable, but it is not a very reliable marker because many factors can affect CD4 count. Even physiologically diurnal variation is there. So the best marker to monitor the efficacy of the treatment is viral load. What is viral load? It is nothing but number of RNA copies per ml of blood. So we are done with RNA PCR. Number of RNA copies, very reliable marker. If the viral load is high, that means patient is not responding to the treatment, prognosis is poor. If the viral load is low comparing with the baseline, that means prognosis is good. So viral load is the current marker for efficacy, monitoring the efficacy of the antiretroviral treatment. P24 antigen, HIV-1 antibody, these are all for confirmation of HIV. This for diagnosis. Diagnostic test. Viral load is a prognostic test. And viral serotype for epidemiological purpose. Some people say Western blot, whatever it may be, even Western blot also HIV-1 antibody detection. Those are all for diagnostic purpose. So the answer here is to monitoring viral load is the ideal tool. So now we are starting the treatment irrespective of CD4 count. We can start the treatment. Next question. Yeah, always there is a question like this, vaccine strain. All our GT and computer based test, one question will be their default. A patient visited Africa and died of a disease. Autopsy shows intranuclear torus bodies. They gave the name torus bodies. Torus bodies is nothing but Cowdy type A intranuclear inclusion bodies, which is seen in yellow fever. It's a direct question. Yellow fever, you remember two type of bodies. One is torus bodies. It is intranuclear inclusion bodies and it causes liver mid-zonal necrosis. That's called Councilman bodies. So which vaccine strain could have prevented this disease? So what is the vaccine strain? So you must know all vaccine strains, available vaccines. There is a table in the revision series we released. I'll show. SA14142 for Japanese encephalitis virus. It's a live attenuated vaccine. Nakayama also Japanese encephalitis virus. It is killed vaccine. Jarelin is for mumps. And 17D vaccine for yellow fever. What is the protection period usually? The protection period is 10 days to 10 days to 35 years or one life. Lifetime or 35 years. 17D vaccine. See the chart we already released for you. These are the vaccine strains. Some people give the choice Danish 1331 also. Whatever it may be. In case of yellow fever, it is. So how to diagnose its yellow fever? Torus bodies. So you must know all kind of intranuclear and intracytoplasmic inclusion bodies, viruses, which includes Nigri bodies, patient bodies, Anderson-Peterson bodies. These are all comes under intracytoplasmic. Lipschultz bodies, Taurus bodies, and adenovirus, as well as poliovirus. This all comes under intranuclear inclusion bodies. You are aware of that. The answer here is 17D. Next is, after seeing the image itself, you can answer. In my mycology, my first question is like this, start like this, in my regular class. A truck driver admitted with cough and breathlessness. Histopathology examination revealed septate typhi with 45-degree angle branching as shown in the image. Identify the correct pathogen. Very simple. Septate typhi with V-shaped branching, dichotomous or acute angle branching or 45-degree angle branching. And what is the feature? What are the features? It causes cough, breathlessness. In case of immunocompromised or neutropenia or any hematological malignancy, it can add more supportive. And also it causes allergic bronchopulmonary aspergillosis, or in the pre-existing TB cavity, they settle as aspergilloma fungal ball. We can vote for aspergillus because it's septate typhi with 45-degree branching. Direct question. These other choices, Rhizopus, Mucor, Absidia, this comes under mucorales, zygomycetes. They are all aseptate or non-septate typhi with 90-degree branching. Some of them have rhizoids-like structures. So easily you can make it. Answer is aspergillus. It's a very direct question. 100% scoring question. I used to tell parasitology and mycology. 100% scoring. And this time, lot of questions we got it from mycology. We'll see. Just I'm giving justification to the answer. A HIV positive person developed fever, cough, lymphadenopathy and hepatosplenomegaly. The infectious agent was yeast at 37, mold at 22. So it is called dimorphic fungi. Produces red color pigment in the culture. That's another clue. Microscopy shows. Even microscopy makes little bit people confuse you with aspergillus. Many of the kids, it look like aspergillus. But aspergillus is not dimorphic. So dimorphic, what is the mnemonic? Follow my mnemonic. Dimorphic is STS. Previous was SPS. Systemic mycosis, which includes histoplasma, coccidioides, paracoccidioides, blastomyces, taloromyces, or Penicillium morniffi. Penicillium morniffi. Next is Porothrix. So definitely it is a dimorphic fungi. So it should be one among this list. I won't vote for Sporothrix because Sporothrix, it won't cause hepatosplenomegaly, cough, fever, those kind of systemic manifestation. Usually it causes rose gardeners disease, subcutaneous infection. So I will not vote. And second thing, if you take culture, it forms flower shape, floret shape culture. And second one is systemic mycosis, all the four. Histoplasma inside the reticuloendothelial cells, finger-like projections. Coccidioides, it forms arthroconidia, chain-like structure. Where paracoccidioides, there is no specific culture form, but it produces yeast form like a pilot wheel appearance. Blastomyces, yeast form is figure of 8, not mold form. So, red color pigment producer commonly seen in intravenous drug abuses in northeastern India is Taloromyces or Penicillium morniffi. Penicillium morniffi was the old name, Taloromyces is the new name. Here, how can rule out? Aspergillus is not dimorphic, Nemocystis is not dimorphic, and we can't cultivate. They won't any, and Blastomyces, it won't produce any pigment, and it is usually figure of 8 appearance. Lot of dermatological involvement is there. So based on that, you can easily find either rule out method, or if you know directly, you can come to conclusion. It is Taloromyces or Penicillium morniffi. Next question. A farmer came with cauliflower-like growth in food. Biopsy shows copper penny body. Some of the people says are sclerotic bodies. I got two type of feedback. Some kids are says copper penny. Some kids are says sclerotic. Some people says both are given. But everybody is confident there is no image was given. INICET exam, you got the image. So copper penny bodies, cauliflower-like growth. Direct question, you can go for Chromoblastomycosis. I'll show the thing to you. See here, it was a DVT slide. Hope you people remember mind mapping. Okay, copper penny bodies. Then they didn't give the image, and this is otherwise called medullary bodies, muriform bodies, sclerotic bodies, all are same. It is subcutaneous fungal infection. Subcutaneous fungal infection. So we can go for chromoblastom. Just a direct question. These are all direct questions. You need to spend few seconds to come to conclusion. Where you see the word copper penny or sclerotic, next minute chromoblastomycosis. What they may ask even next, what is the etiological agent? Claudospora, Phylophora, Acrimonium, Poinsettia, like that they may ask. Or maximum finally they may ask the treatment. Okay. Next is a patient presented with curdy white vaginal discharge. Choose the correct medium used to identify the species of this pathogen. Here also I got two type of question. Very first what my kids send, sir, what is the medium? And they put only SDA and birdside earth. These two only I got first. Very first hand information. I thought question was very silly and direct. After that I got the full version of the question. Okay, so curdy white vaginal discharge. Based on the nature of the vaginal discharge, we can come to conclusion of the etiology. If it is frothy, foul smelling, watery, it may be due to parasitic trichomonas. If it is thick, curdy white, it is vaginal candidiasis, moniliasis. Okay, if it is rotten fish smell, amine odor, you can think of bacterial vaginosis. So it is curdy white, 100%. It is fungal, vaginal candidiasis. All candida will grow in sabrodextrosaccharide. That's a universal medium for fungus. But the question is how to identify the species. For that we are using a medium called Chrome-agar. Chrome-agar not only for fungus, many other places we are using Chrome-agar for candida. That's a full name. Chrome-agar for candida. The manufacturer, they add some coloring substance, chromogenic substance. So each species produce one different type of color based on the manufacturer's instruction. Anyway, they have some common colors, but usually as per the manufacturer's instruction, each one produce one type of color. Corn meal agar to demonstration of chlamydospores. Bird seed agar or Niger seed agar to demonstrate melanin pigment of Cryptococcus. Cryptococcus melanin pigment. Sabrodextrosaccharide is a universal candida, universal medium. Not only for candida, it's a universal medium. So here, if you want to know the species of the candida, go for Chrome-agar. See here, I'll show some picture for you. Yeah, these are all we already posted in the Facebook club and the eMedicoz. So fishy smell, rotten fishy smell or amine odor, you can go for bacterial vaginosis. And where there's a thin molodous frothy discharge, it is parasitic. And curdy white or cottage cheese appearance is candida. And second thing, see, this is called Chrome-agar. for isolation and differentiation of major clinically significant Candida species. Each one produce one color. This for demonstration purpose, all put one color or one medium. If it is the green color, albicans, metallic blue, Candida tropicalis. Pink on fuzzy is Candida krusei, and maybe color is Candida glabrata. Like even more also there. Depending upon the manufacturer, they add different colors for different species. That's called the same thing available for Staphylococcus also. That's called Chromoblastomycosis for Staphylococcus. The MRSA will grow, produce some color. The methicillin susceptible produce some other color. Like that, we can easily find whether it is methicillin resistant or not. MRSA, just seeing the colony, color of the colony, you can say it's MRSA. Like that, Chromoblastomycosis now is famous for many pathogens. Next is, yeah, always we are expecting a question from mucormycosis. After post-COVID, it's inevitable. Many times we got the question. A post-COVID female patient presented with hemifacial pain. I don't know the history of diabetes was there or not. If diabetic, we can add, that gives extra support. Loosening of the tooth. Hemifacial pain, loosening of tooth, post-COVID, or patient may be under steroid or maybe diabetic. What should be done based on high priority? What next you are going to do? So first we need to confirm the diagnosis. First we need to confirm the diagnosis, whether it is mucormycosis or not. Second, we need to know what is the extent of the lesion. And ferritin and HbA1c is not useful to confirm the diagnosis. They may be tell the predisposing whether the patient is susceptible or not. Those things we can get from these two things. HbA1c positive high. Then uncontrolled diabetes or diabetic ketoacidosis, ferritin level is high. This may give input. The person is more prone or more susceptible to get mucormycosis. And nasal swab from mucor is not the diagnostic. Specimen is crushed. And the gold standard for diagnosis of mucormycosis is histopathological examination of skin biopsy. Sorry, biopsy. Skin biopsy, slip of the tongue. Histopathological examination of biopsy specimens. Biopsy is the gold standard. That is more reliable. Number 2, culture. Culture is not much reliable because when you are managing the specimen, mincing, homogenizing the specimen, because they are all what? Aseptate hyphae like this. If any one cut is there, the whole hyphae will lost. We lost the whole hyphae. So yield will be less. If it's not, if you are mincing or you are homogenizing, there are a lot of chances to lose the fungal filaments. So yield is low. Third is PCR. These three are helping for definitive diagnosis, but all three are not there. Here they mention nasal swab. Nasal swab for confirmation of COVID. That's the ideal specimen. Nasopharyngeal swab, not for mucor. Mucor we need biopsy. No use of nasal secretions, other thing and all. Second, we can go for MRI brain or CT brain. MRI is best comparing with CT. It will tell the extent of the lesions. We can't 100% confirm the diagnosis with help of MRI brain, but it gives more value. Very easy. Other takes, except RT-PCR, other thing will take time. Culture take 2 days, 3 days time. Even biopsy also we need to process. But MRI brain within matter of 1 or 2 hours, you can get the report. So next ideal among the choices, best one. They are not asking how to confirm. They ask very practically. Okay, what done on next priority is go for MRI brain. Based on that, you can do 2 things. Your management, if there is no involvement, you can go for empirical conservative management. Suppose if the involvement is there, based on that you can plan for your surgery. Whether it's surgical or medical or combined, everything you decide based on the MRI. Even though biopsy proves, you need to go for MRI. It's integrated. All investigations are integrated. Right. Next is yes. See here, a wrestler presented with itching axilla. The organism produced velvety colonies with underside red color pigment. In the culture, microscopy shows pencil-shaped macroconidia and lot of microconidia. That's all. That one word is sufficient. You can go for trichophyton. It's a dermatophyte, trichophyton. All trichophyton, there is pencil-shaped macroconidia, lot of microconidia. Microsporum, spindle shape, where epidermophyton, there is no microconidia, club-shaped macroconidia. See this image, you remember. This image you remember from my class. Yes or no? Pencil shape or cylinder shape, macro, lot of microconidia. Here spindle shape, macro. Here no micro, only club shape, macroconidia for epidermophyton. Okay, so we are confirming it as trichophyton, but which species? There we need to use. Which species? Red color is rubrum. Red color is rubrum. Usually we have a question on this. This is Trichosporon Scholini. Famous causes. Mentogrophyte is hair perforation test positive. That was the question they asked in the last time. So we can get few questions. Hair perforation test, ectothrix, endothrix, and this kind of question. So red color pigment, trichophyton is trichophyton rubrum. Rubrum means red color. Common people involved in majority of the dermatophyte infection are these two people. We can differentiate them with the help of hair perforation test. Mentogrophyte is positive. It's an easy question, direct question. Next is a 28-year-old lady admitted with fever, nausea and anorexia for 2 months duration. HBs AG is positive. Surface antigen positive. So you remember, that means infection present. Anti-HBC IgM positive. That means disease present. Acute disease. Anti-HCV negative, no problem. What is the diagnosis? It's very direct and very simple. Usually they may complicate many other parameters they give. They may ask about window period like that, a little complicated, but this time question was very direct, very easy. Surface antigen positive, IgM core antibody positive, suggestive of acute hepatitis. Acute hepatitis B. In case of IgG, it's chronic hepatitis. I don't know other parameters they're given or not, but I got the information because people always remember positives. And they say there is no negative was given, sir. So a very simple question. Hepatitis, always we have a question on hepatitis serum markers. And usually every time little complicated will be there. Some other thing they will add. But this time it's very direct and very easy. Acute hepatitis B. Next is a 12-year-old boy came with emergency department complaints of fever for a week, tender hepatomegaly, is also jaundice like hepatitis like, jaundice, cough pain, mild sore throat and conjunctival suffusion. No vomiting, cough or hemorrhage. Urine output is normal. There is no renal failure. No travel history. What is the diagnosis? Okay. So here we will rule out first. Dengue hemorrhagic fever we can't say because it causes body pain, fever, sore throat also there. but no hemorrhage. So you can't say it's a dengue hemorrhagic fever. No dengue hemorrhagic fever. Chikungunya usually won't get hepatomegaly and all, but severe pain, no jaundice. Chikungunya you won't get jaundice and all, but severe body pain will be there. And history of travel will be there, mosquito bite will be there, like that. No. Hepatitis A, GI disturbance will be there. And there won't be any conjunctival suffusion. Usually jaundice will be there, hepatomegaly will be there, and it's suggestive of leptospirosis. It's called Weil's disease because it's a biphasic disease. One is ectric phase. In the ectric phase only you are going to get jaundice, hepatitis, or liver related. Jaundice, hepatitis, what you call hepatomegaly, conjunctival suffusion, everything will be there. Another phase is called non-ectric phase. In this phase, very common is acute renal failure, aseptic meningitis. These are the common features. So everybody thought leptospira means renal failure. It's not mandatory. Few people experience both. We call it as hepatorenal failure. The same thing I given in my class notes also. Hepatorenal failure. Hepatorenal failure. Ectric, non-ectric and hepatorenal failure. So it's not mandated they should have a renal failure. Because maximum we have jaundice and renal failure or the cardinal feature of leptospirosis or Weil's disease. Lot of names are there. Andaman fever, mud fever, rain fever, rat fever, paddy fever, like lot of names are there. So it's a case of leptospirosis. Conjunctival suffusion is the point and there is no hemorrhage. Jaundice, hepatitis. It is ectric phase. That person is on the ectric phase of leptospirosis. Next is, and they may ask what about the medium, many things, EMGH medium, treatment doxycycline and penicillin. Diagnosis MAT test, gold standard. What is false about pseudomembrane qualities? Some people say no sir, they gave the name Clostridium difficile. Whatever it may be, pseudomembranous qualities caused by Clostridium difficile. It is otherwise called healthcare associated diarrhea, which is followed by starting of antibiotics. You are aware of that. So we want a false statement. Oral fidaxomicin used for treatment. Fidaxomicin, I don't know, some people mention oral, some people know sir, fidaxomicin. Whatever it may be, fidaxomicin is the latest treatment acceptable. Next is, pseudomembrane contains leukocytes, fibrin and cellular debris. Yes. Because it is toxin mediated. We have two types of toxin, toxin A and B. A act as a enterotoxin. B act as a cytotoxin. And the leucose and it forms a pseudomembrane which contains fibrin and cellular debris. Because cytotoxin will cause cytoskeleton damage, that cellular debris, they form a membrane. All are correct. IgM is not diagnostic. IgM, they didn't mention which IgM for against toxin or GDH or overall, they didn't mention, just they mentioned IgM immunoassay is diagnostic. Now we can't say it's 100% diagnostic. If they specifically mention IgM against some particular toxin, then we can say, but toxin demonstration, antibodies may not be useful. We need to demonstrate the toxin by using monoclonal antibodies, those kind of things. So here the false statement, IgM is diagnostic. Gold standard is culture. You can go for PCR of toxin gene, demonstration of toxin. These are all helping in diagnosis. Next is A patient was admitted due to sepsis and broad spectrum antibiotic started. She developed diarrhea. After antibiotic administration, diarrhea. Consider previous question. What is used to identify the etiology of the diarrhea? I don't know, one chapter they are asking 2 questions. Okay, no problem. Sometimes they'll confuse you. You thought it may be from some other topic. Now both are from Clostridium difficile, CDI, Clostridium difficile infection. It is called antibiotic associated pseudomembranous enterocolitis. And what is the diagnostic? We can't go for aerobic culture because this organism is anaerobe. Stool microscopy may not be useful because it contains lot of gram-positive organisms. Glutamate dehydrogenase is good one. GDH is good one, but it is present in all Clostridium difficile plus other bacteria. Not specific. So if GDH present means we can say Clostridium difficile present and other bacteria also present, few other bacteria. And Clostridium difficile, there are 2 types are there. One is toxigenic, another one is non-toxigenic. Toxigenic cause disease. They present as a commensal or they present as a colony in the intestine. So if GDH only means glutamate dehydrogenase, first of all you can't say it's 100% Clostridium difficile, other bacteria also there. Even if you say it's a Clostridium difficile, you can't say it is toxigenic or non-toxigenic, you cannot differentiate, no use. So for that we need to go for toxin assay. Toxin assay by ELISA. If we are able to demonstrate the toxin specific Clostridium difficile toxin, that is confirmatory. Easily you can identify. So GDH and toxin assay is very good one. Superior is because after production of the toxin only you can identify. So already she had diarrhea, so toxin already produced, no problem. Some people, if you want to know the susceptible they are going to get or not, we can go for toxin gene by PCR. So before production of the toxin, whether the organism is capable, whether it is toxigenic or not, we can identify. So ELISA after production of the toxin you are diagnosing. PCR before production of the toxin you are diagnosing. And we can start the treatment. If you are able to find the toxigenic strain, you can start the treatment. Now the drug of choices in India, vancomycin. Metronidazole is not in use. Metronidazole was old. FDA not approved now. Vancomycin. And another one for the previous question, naxomycin. Okay. Next is, always we have a question on vectors. There is a table in my class, all vectors and respective diseases. We discussed in TND and many times. Soldier presented with fever, myalgia, rash in body, sparing palm and soles. So some rash is there. 5 other soldiers in the troop also affected with similar illness. So it is contagious. History of exposure to body lice is present. That's a clue. Choose the correct causative organism. So if you know what are all the disease spread by louse, easily you can make. It causes epidemic typhus, Rickettsia prowazekii. Next is it also Tunch fever, Bartonella quintana. Third one, epidemic type of relapsing fever. Borrelia recurrentis. These 3 are the very notorious louse-borne disease. We can't go for Tunch fever, there won't be any rash, other thing and all. It's called 5-day fever. And there is no history of relapsing. Only fever, because rash is present. So rash is present, all rickettsia. And another important thing, if we give some other organism also, you'll get confused. So go for Rickettsia prowazekii. Because Rickettsia typhi vector is, what is the vector for Rickettsia typhi? Is rat flea. Rickettsia acari, mite is the vector. And Rickettsia conuri, Indian tick typhus, tick. Rickettsia acari causes rickettsial pox, mite is the vector. Rickettsia typhi causes endemic typhus, rat flea is the vector. So if you know the vector and the pathogen and the disease, the triad, game over. It will be very easy for you. Easily you can come to, without knowing much clinical thing, you can easily come to conclusion. So it is epidemic typhus. Next is a diabetic patient has rhinitis, facial swelling. Biopsy shows aseptate hyphae with irregular abyss branching. Same topic again coming. It is nothing but mucormycosis. Direct question. Mucormycosis. Because it's diabetic, rhinitis. It's what type of this thing? It's called rhinocerebral mucormycosis. It is rhinocerebral mucormycosis. Drug of choice is amphotericin B, no other go. Make things easier, direct. Amphotericin B. Fluconazole people told, voriconazole told, they don't know about other drug, just I made it capsopangin for completion sake. Even if it is wrong, you can leave it. You can take that. But right answer is amphotericin B, because everybody remember the correct answer. Once they know the answer is correct, amphotericin B, they won't take much pain to remember other choices. If you don't know the question, then you remember all the choice. Psychology. How many questions you can remember? It's a student psychology. If they don't know the question is really tough. They remember the full question, they remember all the choices. If the question is easy, answer is easy, they remember only because what they studied, they applied. So after reading the second line, aseptate hyphae, rhinitis, facial swelling, it's mucormycosis. Treatment amphotericin B. That's all they go to next. With surgical management. Next is a 4-month-old child born to HIV positive mother developed recurrent diarrhea. What is the next step of management? There are two things. First thing, you need to identify the cause for the diarrhea. Second, it's born to HIV positive mother, whether the child is having HIV or not. That is important. At any cost, stopping breastfeeding is not advisable. Whether the child is positive or negative, don't stop breastfeeding. Very initially, 10-15 years before, we used to stop breastfeeding for a period of time. Now it's not like that. Exclusive breastfeeding is acceptable. Second, test for IgM antibodies for Giardia. No, not start antibiotic. That's not advisable. We need to confirm the diagnosis. There are two tests available: antibody and dried blood, DBS, dried blood spot for HIV PCR. I will tell children less than 18 months. Go for DNA PCR based test. DNA PCR is diagnostic, RNA PCR prognostic. I told you from the first question. Again, they are classifying two schemes. One is children less than 6 months and 6 to 18 months. Make it very easy. What is it? 6 months? Less than 6 months. After 6 weeks, do first dried blood spot. That's called a PCR specimen. We have filter paper, we make a puncture and we take the blood spot in the circle. So 6 weeks, do the DBS. If it is positive, send one more sample, plasma. If that also positive, start treatment. Or don't worry, at the end of 6 months, do one more DNA PCR. If DNA PCR. Okay. Suppose if it is positive, if it is negative, do one more. Whatever it may be. At the end of the 18th month, you should do antibody test. Here, little different scheme. 6 to 8 months of age, in case, do antibody test. If antibody test is positive, then go for DNA PCR. Got it? If antibody positive, if antibody negative, no need to do anything. If the child is symptomatic, chronic diarrhea, chronic weight loss, those kind of thing, that time you can do. Otherwise, no need. If after 6 months, because after 6 months antibody test we can't really 100%, because there may be presence of maternal antibody. If the antibody positive means it may be due to mother's antibody also. We can't. So for that we are doing DNA PCR. If the DNA PCR positive means this antibody may be due to from the child. Got it? If there is no antibody means mother's antibody not crossed. That means the child may not be infected. But we can't say 100%. If child is symptomatic, AIDS defining illness is there, then go for DNA PCR. That's the NACO guideline. Just I'll show the image. It's very huge algorithm. I make it. I got it from a slide. Yes, we prepare the slide when I was the master trainer in NACO. Diagnosis HIV exposed infants. Make it very easy. 6 weeks, not at birth. 6 weeks, you do DNA PCR, all HIV exposed infants. After that, 6 months, you need to do one more. In case of more than 6 months, do antibody tests followed by DNA PCR if HIV positive. At the end of 18 months, every child we need to do antibody test irrespective of DNA PCR. That's the point we want to emphasize. Final confirmatory antibody test, all HIV exposed infants at the age of 18 months, irrespective of the early test, whatever it may be. All infected, symptomatic, they need to be referred to ICTC to AIT center for further management. Any HIV infected, anything, you can send it for AIT center. Okay. So, very simple. Children less than 18 months, we totally depend on DNA PCR. The specimen is dried blood spot. DNA PCR, not RNA PCR. RNA PCR for viral load prognostic test. Test for HIV antibody, usually the children more than 18 months. We can go for rapid test, Western blot or ELISA, whatever it may be, but India we are preferring rapid test, 3 rapid tests. Next is, see here, a 45-year-old farmer admitted with sinuses with the discharging granule in the foot. Sinus granules tumor. Remember the mnemonic, GST. Tumor, sinus, granules. If these 3 are there, then we call it as mycetoma. Mycetoma. It is caused by bacteria and fungus. Bacteria we call it as actinomycotic mycetoma, and fungus we call them as eumycotic mycetoma. Actinomycotic, Actinomyces, Nocardia, Streptomyces, those people. Eumycotic, I used to tell my place, I am from Madurai, Majura food, Majorella mycetomatis, remember? Majorella mycetomatis, Majorella graisa, those kind of people. Okay, so it's a case of, and I got different pictures. Some people send this picture, sundry appearance. Some people say this picture. Some people say this kind of picture. So everybody says similar, sir, but not original picture. This is somebody says 90% it's similar, sir. I don't know. Whatever it may be. Even if you don't know the picture, you can make it. It is sundry appearance. In the microscopy, in the culture, it produces molar tooth appearance. So microscopy of the granule shown. It is mycetoma. Choose the true statement. It causes only superficial disease or skin disease. Some choices they say it won't cause deep disease like that. Whatever it may be. No, it is subcutaneous infection. Mode of infection, local inoculation, not hematogenous. Not hematogenous, local inoculation. Splendor-Hopley phenomenon, the eosinophilic material seen in other conditions like sporothrix, very well notorious, and it is caused by both fungi and bacteria. They have different type of granules. Bacterial granules are yellow color, except Actinomyces pelletieri, Actinomyces pelletieri, red color, and all fungal, majority of the fungus are black color and some of them white color. Majorella mycetomatis, Curvularia, these people and all black color, where Aspergillus, Acremonium, Fusarium, these people and all white color. So black and white in fungus, yellow color is seen in bacterial mycetoma, bacterial mycetoma. So it's a very easy question. I don't know which picture, don't worry. Next is, all my kids made the question right. Microfilariae sheath tail and 2 nuclei in the tail tip suggestive of. They say 2 nuclei in the tail tip suggestive of. So sheathed mnemonic is LBW. So here I am removing this. These 3 are sheathed. L for, remember, love. Full talk time, full of nucleus. Wedding, no talk time, so no nuclei. And USMLE, 2 nuclei. Remember this picture. 100% of people remember this picture. I know that. See here. All my test and discussion, all my class, this picture is default because we are expecting 100% a question. Organism may change, but question will not change. Some question we can from the topic. Either sometimes Onchocerca, sometimes Lolova, sometimes USMLE, we don't know. Some question will be there. See, sheath with 2 nuclei is USMLE or Burja timori. 100% we are expecting a question. Now these are all very standard topic. Next is, choose the correct mechanism of action of botulinum toxin. It's a direct question. Botulinum toxin is a powerful neurotoxin, exotoxin. All are neurotoxin except C2 is enterotoxin. Main function, it inhibits the release of acetylcholine in the neuromuscular junction or in the presynaptic area. After acetylcholine, it go and attach with nicotinic receptor or muscarinic receptor. Nicotinic or muscarinic receptor. Usually muscarinic receptor, it causes excitatory effect. Nicotinic also, sometimes excited, somebody inhibitory. Usually it causes excitatory effect. And because of it inhibits the release of acetylcholine, it causes flaccid paralysis. You know the clinical picture. My mnemonic 5D, diplopia or double vision, dysphagia, difficulty in swallowing, dysarthria, slurring of speech. Next is descending paralysis and decreased deep tendon reflexes, 5D. And it causes infant botulism, otherwise called floppy baby syndrome. All the things. So it's a direct question. It inhibits the release of acetylcholine in neuromuscular junction. It won't stimulate nicotinic receptors. That is not the action of botulinum toxin. That is the action of acetylcholine. It's muscarinic receptors. This is acetylcholine. That acetylcholine is inhibited by this one. Norepinephrine not we are using anger or telling lie, those kind of situation we are using norepinephrine we are using. Okay, next is, so we need to know the mechanism of action of toxins. Another important neurotoxin is tetanus toxin, tetanus plasmid, that inhibit the release of GABA and glycine. Yeah, it's a very direct question. Broken vaccine vial is discarded in. Remember, BBB, blue for broken glassware, which include ampule, vial or any glassware. And another one is PBB, metallic body implants. Like metal plates, other thing, body implants. Yellow, remember my mnemonic, fellow. Fellow related waste, our human anatomical waste, the drugs which we are taking, discarded drugs or expired drugs, linen, cloths, bandage for using me. Okay, and microbiological wastes. These comes under yellow, fellow, and the blood transfusion bag, those. White, sharps, metal sharps usually. Red is recyclable plastics. Red is recyclable plastics. That's all. R for R, one word. Red recyclable plastic is the concept. White is sharps metal. What white color metal? Yellow, fellow related waste. Human or anatomical waste, chemical waste, expired drugs, biochemical waste, biotechnology or laboratory wastes. Apart from that, linen, beddings, vomitus, feces, all other thing, everything. Okay, make it very easy. This question usually community medicine will take. Some questions are overlapping, no problem. Yeah. A patient admitted with fever, headache, vomiting, altered sensorium with neck rigidity. That's all. Yeah, up to this, easily you can say the patient is having meningitis. CSF analysis shows slight decrease in glucose and increase in proteins. Slight. Microscopy, lymphocytes are seen. A coagulum of CSF seen. This is called cobweb coagulum because of proteins. Choose the correct diagnosis. Make it very easy. If you are able to see lymphocytes, it's not pyogenic meningitis. Remove chemical meningitis also. I don't know, they put chemical meningitis. Some people say aseptic meningitis. Some people say fungal meningitis. We don't know. Lymphocytes seen in both, but viral meningitis, proteins are normal and glucose is almost normal, but lymphocytes are seen. Tuberculous meningitis, because it's a slow growing organism, so glucose utilization is little less, protein is high, so it is tuberculous meningitis. So you must see the table. Remember the table? Yeah. So bacterial proteins are high, fungal little high, glucose drastically reduced, slightly reduced in fungal thing, and here all lymphocytes, pressure little bit increased, tuberculous normal or increased. So if they gave fungal meningitis, that may be little tough competition to you. But the cobweb coagulum, 100% go for tuberculous meningitis. Cobweb coagulum, you can go for tuberculous meningitis. Make it very easy. Next is, yeah, it's a direct question. Sometimes this question may be overlapping with pulmonology, or it may be MDR, multi-drug resistant. No need to see the choice. What comes to your mind here? Irrespective of any other first line drugs, it must be resistant to isoniazid acid and rifampicin. That's all. Then it is called MDR. Get the answer here and search, it will be right. Then you should know XDR. Now with the change, what is called pre-XDR and XDR. MDR with fluoroquinolones is pre-XDR. MDR with fluoroquinolones along with the newer drug, bedaquiline, then we call it as XDR-TB. So you should know the new definitions for MDR and XDR. Direct question. You are lucky they ask about MDR-TB. These are all 100% scoring. Next is, a 20-year-old female working in a village school developed watery diarrhea, rice water stool. That's all. Watery diarrhea, rice water stool, 90% it is Vibrio Cholera. The pathogen responsible for this condition acts on, what is the mechanism of action of the toxin? It acts on adenyl cyclase, stimulate, and it increase cyclic AMP, outpouring of water and electrolytes, secreted diarrhea. So it acts on GM1 ganglioside receptor. It's a direct question. GM1 ganglioside receptor, that's all. Next is, yeah, this question little controversial in the sense that what we understand from the kids. Female, because everybody is giving little bit of the question, we assembled. I don't know the shape is correct or not. Female came with the clinical condition shown in the image, and many people they mentioned it is anorectal warts. The image gives anorectal warts, that everybody accepted. Histopathology examination shows she is having high risk of squamous cell atypia. That means she is in pap smear or in histopathology examination, squamous cell atypia means more prone to get human cervical cancer. Now the question is, we have two type of versions. Some kids are asking, telling what serotype responsible for that squamous cell atypia, that means cervical cancer. Some kids are saying it is more prone to get that ladies in the risk of cervical cancer, but which serotype responsible for this condition? That means anorectal warts. So if you take this question, if the lady, that woman is having anorectal warts, serotype responsible for this condition is HPV 11, because 6 and 11 causes anorectal warts. Suppose she is in the risk of human cervical cancer, which serotype cause human cervical cancer? That time the answer is 16 and 18. Even 31, 33 also causes human cervical cancer. So I am not having the clarity. So I'll conclude by two ways. If they ask because you are the person who's sitting the exam and you understand what it is, you can put it in the comment box also. Write one, nothing wrong in it. Don't worry. If the question is on what are the serotype responsible for that anorectal warts or condyloma acuminata, that time the answer will be HPV 11. Suppose if they are asking she is more prone or in the risk of human cervical cancer and which serotype responsible for human cervical cancer, that time the answer will be 18, 16 or 18, but 18 is there. And one more thing, anorectal wart, 6 also there. Some people say there is no 6 there. 2. Some people say 31. Lot of points are there. Okay, some people say 2s, 2, 5, 11, 18, like that. Lot of confusions are there. Don't be panic. You know the theory very well, and based on the question, what really they asked, only you know. So if it is anorectal ward, it is 6 or 11 or 11. So 6 is not there. Some people say yes. And second thing, if it is cervical cancer, that time the answer will be HPV 18, depending upon. One more controversy question is maybe the last question, 24th question. Yeah. 5-year-old child admitted with fever, pain, swelling of knee joint. He also complains of upper respiratory tract infection. On examination, he is pale. Some people say they mention is anemic. X-ray revealed lytic lesions around the distal end of femur. Somebody says metaphysis, and they say actually they give the features of osteomyelitis. So they say, sir, it's a osteomyelitis case, sir. You feel something related to osteomyelitis. Like that, I got the thing. Some people beautifully mentioned the same thing. Okay, and peripheral smear shown in the image. See, peripheral smear, because anemic, so they did the peripheral smear. X-ray suggestive of osteomyelitis. Sickle cell. So the question is, sickle cell patient more prone to get which type of osteomyelitis, or etiology of the osteomyelitis in sickle cell. Usually overall osteomyelitis, always people say Staphylococcus aureus. That is overall. But some conditions are there. In case of diabetes mellitus, intravenous drug users, Staphylococcus aureus and equally Pseudomonas is important. In case of prosthetics, use of prosthetics, that time viridance is important. In case of sickle cell patient, salmonella typhi is important. And everybody made it correct because everybody knows sickle cell patient, salmonella typhi. So they know only 3 keywords: osteomyelitis, sickle cell, salmonella typhi. That's all. They made question right. But how they framed is very difficult to get from the student because the question is very easy. See here. Yeah, this is the thing we used to post. Osteomyelitis. Clinical microbiology. See here. Salmonella typhi, enteritis, sickle cell anemia related predisposing factor. Overall most common is Staphylococcus aureus. Pseudomonas, usually puncture wound, diabetics, intravenous drug users, those kind of things. So with this, there are 24 questions we have discussed, more than 1/10 from one subject. Many questions are overlapping. This question orthopedics, because integration, and another MDR TB, pulmonology, meningitis question. Even biochemistry people take coagulum, pathology people can take, discuss, and few questions dermatology people discuss rash, wherever comes, whatever it may be. Okay, so as per the information what we received, we give our best to you. Hope you did well, and any queries or anything, you can comment it or you can inbox us. And thank you very much.